And thank you very much for joining this ACNS WIN webinar. It's truly an honor to chair this session. My name is Kurosaki, Tottori University, Japan, and I am the chairperson for this session. This session consists of three presentations. One is Professor Kazuhiro Hongo and Dr. Nehal Shaban and Suzuki, Dr. Mario Suzuki. Now we are going to start with a presentation by Professor Hongo. Professor Hongo is the Professor Emeritus Shinshu University. Now he is the director of Inner Central Hospital. Please, Professor Hongo.
Thank you very much, Professor Kurosaki, for introducing me. Well, thank you very much for giving me a chance to present this prestigious seminar, Professor Yoko Kato and Roger and Dr. Liu and so forth. Can you see my slide?
Yes, yes.
Okay. Well, my talk today is how to avoid vascular complication intraoperatively. I'm focusing on retraction work and high-speed drill. And just 2 points. Well, as I was introduced, I retired from Shinshu University 5 years ago and now moved to Inner Central Hospital. You can see here, it's a very nice place also. I'm enjoying working here at the Inner Central Hospital. Well, there are various steps causing complication. Including surgical indication, preoperative evaluation, planning of surgery, surgical simulation, surgery itself, and postoperative management. And surgery, regarding surgery, surgical complication includes arterial injury, venous injury, cranial nerve injury, brain contusion, CSF leakage, and so forth. Well, today I will show just 2 cases of my varied experience of having complication. One is arterial and the other one is venous injury. And I'd like to share my such experience with especially young neurosurgeon, not to have similar experience. Well, here's the first case, 76-year-old woman having craniopharyngioma. The goal is not to total removal, just the subtotal is good enough, I thought. And I did surgery with left pterygium approach. And you can see the video here. After this is the nearly final part of the procedure. The tumor in a prechiasmatic system was almost removed. And now the tumor in the optical carotid space is being removed piece by piece using ultrasonic aspirator and suction, so forth. Now you can see the situation using spatula here to a little bit widen the operative space here. I think some of you may notice the change in this part now magnified, and here you can see now retracting the internal carotid artery with suction tube. Now here is the massive bleeding occurs. And now after this event, I suction with a large suction tube to expose the laceration point, bleeding point, and eventually the big laceration of the internal carotid artery was found. And eventually, the internal carotid artery was transected. But fortunately, monitoring MEP and SCP monitoring didn't change much, and flow of the middle cerebral artery we can check. So after hemostasis, the surgery was completed after some tumor remained. So this is the case. Then here, 2 days after surgery, you can see the CT scan, the big infarction. And of course, the patient had the severe hemolysis, and right side is 4 years post-op. During this station, the patient was transferred to the rehabilitation center. This is very, very bad case I experienced. This is by my own procedure. Now, here you can see Professor Keiichiro Sugita. He was the first professor of Shinshu University Department in Neurosurgery, came to us to Matsumoto 1978. And here is the microsurgical atlas he published soon after he moved to Matsumoto, 5 years after came to Matsumoto, showing various difficult cases. And among one of the drawing he wrote, here is the picture. The internal carotid artery was retracted by the spatula, and here is internal carotid artery is also retracted to widen the operative field. I think this maneuver is very important for doing surgery nicely, efficiently. Well, the gentle retraction can be achieved with a spatula like this, fixed with Sugita multipurpose head frame like this. And these days, when I was quite young, I wrote one paper regarding monitoring retraction pressure on the brain. I prefer using spatula brain retractor. Of course, Professor Sugita did so quite well. And back to the previous case. Now you can see here is the before causing the disasters, and right side is just before. You can see the change. Now here at this moment, already subadventitial bleeding a little bit occurred, and here is enlarging. But at that time, I didn't notice. So that is very bad. And just before causing big bleeding, the spatula was too much. The shape of the internal carotid artery is like this. So from this event, take-home message: retraction mark of the vessel, no excessive retraction, and no retraction of the, especially for sclerotic artery, especially the proximal internal carotid artery near the carotid ring. It can be moved, anchored. The middle cerebral artery is a little bit different, but here, this point cannot be retracted too much. And next case, second case, venous injury. Also bad experience. Here is the 43-year-old woman having the left ICA paracranial aneurysm incidentally found. Now, this just before the endovascular era, we did direct surgery clipping. And here the procedure, now you can see the door was retracted, reflected, and cottonoid are removed and put the rubber to cover the cerebral cortex, and then anterior cranial process is being removed with high-speed dual. Here, I'm trying to use the dual gently, but now the rubber was being grabbed with this dual, but the flow of the venous Sylvian fissure eventually quite likely preserved. And then after removing the remaining anterior canal process with bone curette, and then the GO procedure is being proceeded to grip the aneurysm correctly without problem. Now, here showing the post-operative MRIs, and fortunately, the patient did well without any deficit. But the point is the high-speed doing. A key point at doing the remove all the cottonoid parties, protect the brain surface with rubber sheets, but not too much, and steady handling like this, and doing on and off at the operative field, and adequate irrigation to prevent heat injury, and appropriate selection of a bar is also very important. Lastly, there are two types, diamond and cutting. There is several characteristics. Cutting is efficiently removing the bone, but the point is grabbing, quite easily grab the surrounding structures, even rubber. And the appropriate angle of the bar handling is very important. This is the appropriate rather than this causing damage nearby structure. And direction also very important. Not this, but this away from the critical structures. Otherwise, quite easily grabbing tissue damage may occur. So here, diamond cutting, and the other one is bone curettes. Currently, it is available in many institutes. Motion of the tip of the curette is like this. So torsion motion, and no rotation. So this is good for not causing grabbing. So this is very safer point. Efficient, not less efficient than do, but the stepwise bone curette usage is good for removing the bone in very critical structure site. So high-speed process, efficient bone removal is possible, and an operating microscope in the skull base near the vital structures. But on the other hand, possibility for causing injury, like the case I just showed, by grabbing vessels or nerves, and also by causing heat. So appropriate usage is mandatory. So take-home message regarding usage of the drill. The high-speed drill is efficient for bone removal, but may cause disastrous tissue damage and needs to be used properly. And bone curettes are safer alternate tool. Well, in conclusion, I just presented two cases of intraoperative vascular complication. The purpose is to share my bad experience with young neurosurgeon, not to have similar experience. And 2.1 is appropriate retraction work was stressed, and proper usage of a high-speed drill was stressed. Well, thank you very much for your kind attention.
Professor Huanggo, thank you very much for your nice presentation. And also you presented so instructive cases for not only young neurosurgeon, but also the old neurosurgeon. Do you have any other, comment or questions from the audience? How about Dr. Shah?
Thank you, Professor Ango. That was a very beautiful and elegant presentation to show how during the drilling, if you keep structures around it, you have to be very careful. And sometimes when the patty wraps around it, it can really cause a disaster. So it is nice to know that, you have to prevent it and know the indications of using diamond drill over the cutting burr when necessary. And these are important things that we remember during tumor surgery. So these are good cases that you have shown to see the complications. Can we ask our discussions for some comments? Professor Kalangu?
Thank you very much for allowing me to give my opinion. Congratulations to Professor Kazuhiro Ongo. It's really, your presentation is very, very educative, particularly from somebody like you who has got a wide experience to show to young people that accident can happen even in the perfect hands of neurosurgeons. It's very important. I've loved a lot your teaching how to use the curette, for example, which movement to avoid and which movement to use. That's so important. This is not emphasized in a lot of books. They just say use curette and then does it. But those movements are very, very important. Same thing for the drill, okay? Diamond drill or the other drill, it's very important to know which one to use and how to use it. I would say thank you very much for this teaching. It's very important to know how to avoid complications and how to use properly the instruments. Even though they are very, very modern and expensive, but at the end of the day, it's the surgeon, the way you use them, which makes the operation very safe. Thank you very much and congratulations again.
Thank you very much.
Professor Kato?
Thank you very much, Hongo Sensei. Excellent talk. Congratulations. Do you have some differences, vascular lesion and tumor lesion? Because sometimes the tumor lesion is such kind of the perforators all covered by, surrounded by the tumors. So if you have some hint, just this, please.
Yeah, thank you very much. It's a great, important point Professor Kato mentioned. Even the tumor surgery, well, I have one or two similar case, vascular injury case of the tumor surgery. Of course, we can notice the preoperative from the MRI and CT vascular structure inside the tumor. Even tumor removal, we need to really carefully remove the tumor, QSA, ultrasonic aspirator, or drill, whatever, near the vascular structure. And in that case, tumor cannot, during the tumor removal, I think Doppler sonography, Doppler echo sonography is very handy tool to detect the vessel structure, vascular structure. Yeah, thank you.
Thank you so much. Very informative. Thanks so much. So do you use ICG? Is it effective or?
Yes, it's also quite effective, but the ICG only can show us the vessel, the surface. Just one or even 1 or 2 millimeters depth cannot show us. So in the case, the echo Doppler fluorometer or echo is more efficient. So we can use both.
Okay.
Tools.
Thanks a lot. Thanks so much. Sharon?
Yes. Sharon, are you there? Would you like to say something?
Unsha? No, Sachin.
Okay. Yes, Sachin. You can also ask Professor Kostadin to make a comment while Sachin is getting ready.
Well, thank you very much, but I couldn't listen to the very instructive lecture of Professor Hongo from the beginning because of some connection problems with Dr. Liu. So I really appreciate all his contribution, but unfortunately couldn't get the details. Thank you very much for the opportunity.
Yes, Sachin. Sachin, unmute.
Okay. Am I audible now?
Yes.
Okay. Thank you very much for Professor Hongo for a fantastic lecture about the complication. Just wanted to share one unusual complication. I don't know whether you have come across such a thing or not. We had a case of PCOM aneurysm, and when we were dissecting the ICA and then later PCOM and other perforator, we had not drilled the skull base very flat, and because of that we had to use the light on the very high definition, very high light of Pentero 800, and in between the ICA at one point where the perforator got ruptured, and we concluded that probably it was because of that too much high intensity light. So after that we are doing our eye all the high maybe magnification work with the Mitaka microscope. We have both Pentero and Mitaka. In the Mitaka microscope, you have that switch where your light is maximum. You can put that switch, and that switch is for heat cooling. So whenever the light is very high, it creates a heat, and that switch, it will give you heat cooling. So because of that, the temperature will come down. The light will be maximum, but temperature will come down, or you can keep on irrigating. So just wanted to share that whenever you're putting your light maximum, make sure you are irrigating or switch on that height cooling option. Don't know whether you've come across anybody came across such a complication.
Thank you very much. I think it's a very important another point. Too much intensity light is also bad for surgeon here himself or herself to protect on the eye side. Thank you very much for your nice comment.
Thank you.
Professor Ahmed.
Hello. Thank you for a great presentation, and it's good to show our experience for young neurosurgeon. But just I'd like to know your advice for nowadays. There's high-speed drills, but smart high-speed drills. The perforator is not cutting the soft tissue, and if it's available, do you think it's better, or you still advise for a period? Thank you. I'm from Afghanistan.
Thank you very much. Well, high-speed rule is very convenient, efficient, but without using correctly, it causes big problems like the case I showed. So currently, alternate tools have been available. So we need to, of course, training of the high-speed rule usage is very important, but the using safer alternate tools are also we need to think about. Thank you.
Thank you, Professor Hongo. I think we can move ahead. I'll hand over back to Professor Kurosaki to introduce the next.
Yeah, my question is about the first case, craniopharyngioma case. How do you treat with the residual tumor? Because maybe that tumor would be growing or change to the cystic formation. How did you treat?
Thank you very much for your question. This patient, the age 76 years, and some tumor residue, of course, but if the residual tumor grows again, we'll think without the radiation or other non-surgical procedure if the patient's condition is good. Thank you.
Thank you.
There is one question from the audience by Mohammed Shahnawaz. Preoperative vascular injury controlled with low current bipolar. Do we have to do angiographic PSA to check development of dissecting aneurysm? If yes, what should be the protocol?
Sorry, I can catch the question.
So if
I cannot hear.
I think what he's asking is if there is some if you control some bleeding with a little bipolar, not the whole vessel, just the vessel wall, then should we check post-operatively to see if there is any chance of a dissecting aneurysm? I think that is what he's asking.
Oh yeah, that's very important. Even small, the arterial injury, we need to check post-operative vasculature angiogram whether the dissecting aneurysm may occur or develop. Yeah, that's a good point.
I think if there are no other further questions, we can move ahead. Professor Kurosaki, can you introduce the next speaker?
Okay. Next speaker is the Nehal Shaban. Nehal Shaban is joining this session. No. From Egypt.
Yes, she's here. She's here. She's here.
Yes, yes.
Okay. So please, Dr. Shaban, can you hear me? Not yet. 入ってられます加藤先生。
入ってますよ。Nehal? Can you hear us? We cannot hear your voice. Nehal? We cannot hear your voice.
Oh, これか。
Check your speaker, Nehal. We cannot hear you.
Professor Nehal. Yeah. Professor Nehal, can you hear me? No.
I think she can hear us, but we cannot hear her. Nehal?
Yes.
Mm-hmm. Some trouble.
Yeah. Can you check the speaker?
Maybe Avidasha, maybe some of you can send her a message, please.
Okay.
Then,
maybe Professor can introduce the next speaker and we can.
Yes, I think so. Yes.
鈴木先生、先に行ってもらっていいですか？
わかりました。
So next speaker is Professor Suzuki Mario, Juntendo University School of Medicine, Tokyo. Please, Professor Suzuki.
So can you see and can you hear me?
Yes.
Okay.
So thank you for inviting me, and it is a great honor for me to have a wonderful opportunity. So before my talk, I briefly introduce myself. I grew up at Shizuoka Prefecture in the middle of the Japan, and you can see the beautiful Mount Fuji from southward. So after graduating the Kansai Medical University in Tokyo, I moved to it's in Osaka, sorry. I moved to Juntendo University and started the career as a neurosurgeon. And I have a chance to go to Chicago for the research work at the Children's Hospital in Chicago, United States. I obtained my thesis in pediatric brain tumors, especially on genetic analysis of ATRT. So I am the person of pediatric brain tumors, and today I'd like to talk about pediatric brain tumors in posterior fossa. So as you know, posterior fossa tumors are more common in children than in adults. Brain tumors are the most common solid tumor in pediatric population and the most common cancer deaths in children aged under 15. The clinical presentation depends on the site of the tumor, biological behavior and aggressiveness of the tumor, and the rate of the growth. At the time of the presentation, most of the patients show severe headache or frequent vomiting due to obstructive hydrocephalus, and also symptoms due to focal compression of brainstem and cerebellum appear. So the graph is the incidence of pediatric brain tumors. The three most common pediatric brain tumors are medullary and ependymoma and parasitic astrocytomas. And you can see there is a characteristic images. So the parasitic astrocytoma typically shows the nodular lesion with cysts. And ependymoma, it grows like a open corridor from post ventricle to cistern. But most of the tumor is detected when it is gross in the large size and making it difficult to distinguish on imaging. When you look at the floor of the post ventricle, you can see the CSF line is here. It should be the medulloblastoma because the medulla is originated from the 𝑣𝑪𝑵𝑺. But how about this case? You can't see the line of the CSF, so you guess it is medulloblastoma. But this diagnosis is parasitic astrocytoma. Diffusion image is helpful. It's not like a very high signal, but the high signal suggested that the aggressive tumors like a medulloblastoma. So anyway, it is often found in the large tumors when they came, and the surgery is inevitable. The roles of the surgery are very numerous, and I think the most important is to make a diagnosis. On the tumor samples, you can make a histopathological features, and also molecular background are explored, and to make the integral diagnosis. When you get the integrated diagnosis, you can choose the best treatment. So some patients can be free from the tumors by gross total removal, such as parasitic astrocytoma, while others require subsequent radiation therapy and chemotherapy. In addition, integrated diagnosis provides information of the biological characteristics of the tumor, which can be used to predict the future clinical course of the disease. And another important role is to manage the intracranial pressure by removing the tumor and CSF diversion, releasing the surrounding tissues and nerves that had been compressed by the tumor, resulted in the improving symptoms. So before surgery, we should think about a lot of things, like how to make a position and how to cut the dura and anesthesia, the neurological, physiological monitoring, and what we should use, like a microscope or exoscope. I don't have enough time to explain everything, so let's move to the representative cases. So there are two main routes to the fourth ventricle. The one is median route, and the other is lateral route. You can choose which route. It depends on the tumor location and tumor origin. So this is a case of ependymoma. The MRI showed the tumor is located mainly in the fourth ventricle, and you can see the CSF line at the floor and the roof of the fourth ventricle, and tumor is extending cistern portion like through the foramen Luschka and foramen Magendie, and also tumor is deep falling into the cisterna magna. So this is a video after the craniotomy, the C1 laminectomy is now added because the tumor is fall into the system magna, and the dural incision is made on the C1 level, and you can see the tumor through the arachnoid. Then the arachnoid is cut, the CSF is drainage. And after the drainage of CSF at the C1 level, we cut the here the dural incision. And there is a marginal sinus here, and there's so you should check the preoperative images and how to manage control the bleeding. And the opposite side, we coagulate the very well and then cut it. So the tumor is exposed like at the cerebral vallecula, and we cut the arachnoid and just dissect it from the tonsil, cerebral tonsil. Like that. So the tumor is very large, and we need the decompression first. Sorry. So we use the QSA and decompression very well. And then we lifted the tumor, and you can see the fourth ventricle here. And now I'm cutting the cerebromedullary fissure. And you can see here is a cutting port and fourth ventricle. And then you pull the tumor and again decompression with the QSA. And here is the right side of the tumor. So the right side, the tumor is extended to the cistern. You can see the lower cranial knob here, and cerebromedullary fissure is opened by the tumor, so you don't need to cut so much. And the next step, the uvula, and we dissect the uvula and the tumor. So this is the upside, and then get into the fourth ventricle. And as predicted, the preoperative images, the roof and the floor, the tumor is not really adhered, so you can pull like that. So finally, there is attachment was left. So here's the attachment of the tumor, but we can't remove everything because of this is the floor of the fourth ventricle. So we need to the residual tumor is it is really hard part to treat, and you can see the aqueduct. So in this approach, the preoperative assessment is very needed, especially in the variation of venous drainage. So especially in the patients which has well-developed occipital sinus, the amputation of the marginal sinus can cause venous obstruction and lead to serious complication. So here is a case of parasitic astrocytoma. The tumor is located on the right cerebellum, and the MR venography showed the sagittal sinus is directly flow into the occipital sinus, and the marginal sinus is also enlarged by the flow. So you can't cut this both marginal sinus. How to treat these tumors? So we choose the cut of the CINA side and then lifted the dura like upward, and then make a surgical view. So you can see the developed occipital sinus here and cut the dura here. This is a left side, but the tumor is located on the right side. So it is a very developed occipital sinus, and we clamped with this instrument and then coagulate and cut. So this is the left side of the tonsil, and the midline is here. And we cut a little bit more this part and then retract the dura. And here is the right side of the cerebrospinous fissure. And then we dissect the arachnoid and get into the tumor using the navigation system. So this is a post-op images. We cut the CINA part of the marginal sinus and a little bit cut the bottom of the occipital sinus, and then look at this corridor. So I will show you the last case quick. This is a ependymoma case in adult. The tumor is located just located in the foramen of Luschka, and tumor extend both cistern and fourth ventricle. This case, both of median and lateral approaches are considered as a reachable regions. So we choose the lateral approach. The lateral craniotomy was performed and dura opened. You can see the tumor here, and dissected the lower cranial nerve, and the cisternal portion of the tumor was removed. Here is cut the terra choroidea and open the fourth ventricle, and you can pull out the tumor from the fourth ventricle like that. So here's a fourth ventricle. So in conclusion, a brain tumor was the most devastating forms of the human illness, especially when occurring in the posterior fossa. When patients come to the hospital, they often need therapy urgently, and neurosurgeons do not have sufficient prep time in scheduled surgeons. We need to devote ourselves to our studies on a regular basis. Thank you.
Thank you, Professor Suzuki. And Dr. Shah, please.
Dr. Suzuki, that was a very good presentation. And
Thank you.
yeah, so we operate our posterior fossa tumors generally in the sitting position.
Oh, yeah?
Yeah, so normally I would not remove the rim of the C1 lamina, because I get that much space, when I release the cisterna magna, I can easily reach the tumor. And we get very huge tumors basically. So, and in sometimes they are very small patients, in 1 year, 1 year child, 1.5 year child. And sitting position helps us. It's difficult for the anesthetist, but for the surgeon, it becomes a very good position. Have you operated on some brainstem fourth ventricular hemangioblastomas? Solid hemangioblastomas of the fourth ventricle?
Yes.
So what is your strategy for such tumors?
So we usually do the angiography before the surgery, and what is the feeder we should detect at the first, and then using the MRI, the venous draining, we should detect like the surface or like a deeper, and then just keep the venous drainage, and then just how to say just cut out the feeding artery, and then try to remove the like nodularly.
Oh, I'm talking about the brainstem surface.
Brainstem surface.
Sometimes, they arise from the floor of the fourth ventricle itself, and the surgery becomes challenging.
Yeah, it's challenging. So I don't have the experience of the hemangioblastoma, but the cavernous angioma, when it is exposed at the floor of the fourth ventricle, it's easier than it's in the deep size.
Professor Hongo, you have any insight on brainstem solid hemangioblastomas?
Hemangioblastoma in the brainstem, I have no experience, but I think it's very hard to remove it than the cavernoma itself.
So I have operated about 4 or 5 huge solid hemangioblastomas. The problem comes on the brainstem surface, because once you detach it from there is bleeding from the brainstem, which is difficult to control. And if you try to dissect it, you can damage those, vagal nuclei, and post-operatively the patient gets into a tracheostomy, and so little bit challenging. So I was just wondering if you have faced such a similar situation.
So Abida, maybe please go ahead.
Dr. Chuck, I cannot raise my hand, I don't know, because I use the telephone.
Okay.
So, I have small comments. May
Yes.
Can I?
Yes, for sure.
First of all, about the brainstem cavernoma. It depends. It depends if it's situated on the surface. You have a chance to remove it. But if it's situated deep in the brainstem, it's better not to touch it at all, because it's better to use some palliative treatment and all, from my experience. Really disastrous surgery, and functional results are awful after the surgery like this. It's my opinion.
Okay, Dr. Wozniak. Professor Kato, you were saying something?
Yeah, I want to ask, because the hemangioblastoma, is it worthwhile to operative embolization or?
Oh, no,
Posterior fossa.
No, posterior fossa coming from the floor of the fourth ventricle, not embolized.
Okay,
solid, no cyst, solid hemangioma.
Solid one, okay.
We tried, Professor Kato, we tried, yes. But we got a lot of embols to the cerebellum with the patient deterioration. The flow is very high. The velocity, the flow is very high in these cavernomas, and it's very difficult to embolize them effectively.
Yeah. Mario Sensei, what about you? In your strategy, do you sometimes use embolization, or?
No.
No.
We don't use embolization before the surgery.
Okay. Thank you. It's a wonderful talk. Thanks so much. Very, very difficult cases.
I have one more question.
Yes.
Can I to Dr. Suzuki?
Yes, sir.
Can I ask?
Yes, yes, please.
Yes, Dr. Suzuki, thank you very much for excellent case, for very good videos. But you told about midline approach. Midline approach to the fourth ventricle, it's only the beginning of the procedure. Then how do you extend the approach to the fourth ventricle? You know that we cannot cut the vermis, because we may cause the mutism. to retract it, it's also very traumatic. So I think we usually use the telometer approach. So we dissect the vermis and hemisphere from one side. If I need more space, more room, I perform the dissection on the both sides to prevent the retraction and trauma of the vermis. What is your experience? Maybe in children it's not so important. I don't, because I deal most with the adults.
Thank you for your comment. And we try to not to cut the cerebellum, so we usually keep the cerebellum like a brain function, but it depends on the cases. So the medulla, it originates from the vermis, and in the case of the medulloblastoma, we cut the vermis and splitting to make a more resectable region. But the ependymoma, we don't use like that cutted the vermis splitting or some other like cuts.
Okay, thank you. Thank you.
Dr. Kalangu?
Thank you very much. Congratulations, Professor Mario Suzuki. It is a very nice presentation, well explained. Okay. I'm experienced with the telovela, midline approach. I try to avoid the lateral approach, and I've been most of the time very happy with that approach. And like you, I do the laminectomy of C1 when the tumor is going down, and it helps because we are using the lateral position, not the sitting position. For the reason is that it requires complex monitoring, which we do not always have. And so we prefer then to do lateral position. My question is, in your experience, did you have children with cerebellar mutism?
Yes. I have some experience of the cerebral mutism, but they improve within the longest one. He took maybe a half of a year or something. It takes long, but most of the patients, they recovered within 2 weeks or something. Is it the answer for you?
Is there yes. Now, is there any advice you can give to young neurosurgeons to avoid
to prevent the cerebral mutism? Right. So
yes,
it is a very difficult point. So the first of all,
besides the prayer, but how do you prevent
it? But it depends on the cases, as I told before. So the case of the medulla, we should remove the bottom part of the vermis to make a gross total removal, and then they get the cerebral mutism. But other cases, just keep the vermis. I don't use the vermis splitting so often, and they don't get the cerebral mutism after the surgery. So that is a point, I think.
Professor Kalangu, maybe.
Thank you very much.
Sorry for
yes,
that.
please.
Maybe I can add some comment to that. So the mutism basically occurs because of injury to the dentate nucleus and the dentate thalamic tract. So that anatomically lies at the level of the junction of, where the inferior and the middle cerebellar peduncle come very close together to the cerebellar surface. It is just very close to the vermis at that junction. So if you enter the vermis on the inferior aspect and then just lift it up, you will most probably avoid getting that picture. Don't go at the junction of the vermis with the cerebellum. Go just inferiorly and go up.
Thank you.
Okay. Yeah. Thank you very much. Thank you very much. Thank you very much. Congratulations again, Professor Mario Suzuki.
Thank you so much.
It was nice to follow your presentation. Thank you.
Thank you.
Dr. Kostadin?
It's very difficult to speak after so nice comments, Ghayyabi, and also the excellent lecture that Dr. Suzuki presented. It was very instructive. I think that will be very useful for the young neurosurgeons because we have to remind them. I'm in favor, definitely, of adding cerebellum medullary fissure opening because this reduces the trauma. I experienced also, I remember in my past practice, 2 cerebellum mutism, and in both cases, actually, there was some kind of vermian involvement. And using some kind of anatomical reference, particularly for the young, is very important, like orbix inferior, caudal loop, and so on, so we can follow the plane of the fourth ventricle and so on during the removal. The second thing is the importance of the consistency of the tumor. Soft tumors are much easier story for operating than hard tumors, and that is about the venous pattern. Extremely important. A very minor blood loss in a child can be really dramatic because of the low circulating volume. So, very instructive from the young neurosurgeon. I just tried to summarize that. Thank you, Dr. Suzuki. It was very interesting. Thank you.
Okay. Are there any other questions? Professor Kato?
No, it's fine. Thank you very much. So please continue, Mario Sensei, the skill improvement. Thanks a lot. Are you a member of the Dr. Kondo Sensei, the Kondo team? Mario Sensei?
Yes.
Do you belong to the Kondo Sensei team? Okay. Thank you.
ياسر عندي مشكلة في السكرين.
I'll close the PowerPoint and open it again.
Sorry for the time. Now you hear me? Yes, and the screen.
We can hear you, but yes,
Very sorry for this long time. Very sorry. %, a case of pituitary metastasis. I would like to thank Professor Dr. Ahmed Atif Professor of the Neurosurgery Department at University Hospital, and Professor Mustafa Sharif, Professor of the Surgery Department. Pituitary metastasis is a rare condition first reported by Ludwig Benjamin in 1857 and then by Herb Cushing in 1913. The pituitary metastasis account for less than 1% of clinical intracranial secondary tumors. It has been estimated that 1.8% of all surgically resected pituitary masses are metastases. Pituitary metastases occur most often between the ages of 60 and 70 years old, and the incidence is unaffected by gender. There are 3 mechanisms of the metastasis to the pituitary gland. The hematology spread. Pituitary has a very rich blood supply, and the other mechanism is the circulating cerebrospinal fluid. And less commonly, bone metastasis to the base of the skull can erupt the bone from the surface to compress or invade the gland.
Nehal, We cannot see your screen now.
differentiate between pituitary adenoma and pituitary metastasis on radiological basis only. Differentiation between them is usually done on the clinical presentation. They are usually associated with antipituitary dysfunction and visual field defect. Diabetes insipidus primary presentation of symptomatic metastasis. The pituitary may be the first manifestation of an oval primary tumor.
Nehal,
Yes.
we cannot see your slides.
Oh,
Unshare your screen and share again. Unshare your screen.
yes.
Close your PowerPoint. Open the PowerPoint again and share again.
Okay.
Now share again. Now share your screen. Now share your screen again.
Okay.
Not yet.
Now
No.
you see my screen now.
No. Yes, we can see. Put it on full screen now.
Now it will
Yes. Yes.
so again for this side, and I will be very pituitary metastasis is a rare condition caused by lodging benign in 𝑬𝒑𝒂𝒓 and then by harvesting in 1938. The pituitary metastasis account for less than 1% of intracranial secondary tumor. It has been estimated that 1.8% of all surgically resected pituitary masses are metastasis. Pituitary metastasis occur most often between the ages of 60 and 70 years old, and the incidence is unaffected by gender. There are three different mechanisms for the pituitary metastasis. The hematological state, because the pituitary has a very rich blood supply, circulating cerebrospinal fluid, which can act as a vector for malignant cells through the central nervous system. Less common bony metastasis at the base of the skull can erupt from the bone surface to compress or invade the gland. It is difficult to differentiate between pituitary adenoma and pituitary metastasis on radiological basis only, especially in cases where the pituitary metastasis presents itself first by pituitary dysfunction. Differentiation between them is usually done on clinical presentation. Pituitary adenomas are usually associated with antipituitary dysfunction and visual field defects. Diabetes insipidus being the primary presentation of symptomatic metastasis, the pituitary mass may be the first manifestation of an occult primary tumor. The pituitary that has a presentation of pituitary because it has a direct systemic circulation, whereas the antipituitary receives blood through the 𝑘𝑰𝑵 system, which has an anti-coagulation effect protecting the anterior lobe. Also, the posterior lobe has smaller size than the antipituitary, so the smaller volume of mets can be presented earlier than the anterior lobe. Also, involvement of massive and destruction, involvement and massive destruction of the optic and paraventricular material in the hypothalamus can cause diabetes. This is published study titled Pituitary Metastasis, a rare condition, which is published in 2018. In this study, they present a case of series in pituitary metastasis from the City of Hope National Medical Center. They reported 11 cases were recorded between 1984 and 2018. Also, they reviewed the relevant literature from 1957 till 1918. Total of 289 deuterium tests have been reported in this time. The mean age of the patient was 56.6 years old and 52% were female. They found that breast cancer was the most frequent primary origin of metastasis. The visual involvement was the most common primary manifestation. The posterior part of the pituitary is more susceptible than the anterior part for metastasis. The frequency of the primary pituitary symptoms, the visual involvement for 48.8%, the band hypopituitarism 37.7%, the beast insipidus 38.4%, and the headache 35.3%. The frequency of the primary site in the clinic, or they found the breast the first most common, followed by the lung and the thyroid gland, and the bachelor carcinoma or liver metastasis were the first most common site. The patient with breast cancer has digital metastasis 9 times more frequently than other cancer, but in the city of what series breast cancer and lymphoma were equally the most common primary metastasis. Recent studies have found that anti-HER2 treatment can facilitate pituitary metastasis in patients with HER2 positive breast cancer. The lung cancer is the second most common source of pituitary metastasis. The breast and the lung cancer account for about 50% of pituitary metastasis. The fifth most common is the hepatocellular carcinoma. In this presentation, I will present a very interesting case. All the measurements of the cell development with one non-specific laying of patients. This is only not significant of the examination of normal, and there were no clinical evidence of non-significant or significant abdominal distension. Routine initial investigation, including complete blood counts, liver and renal function tests were normal. The CT and MRI readings contrast were done, which were suggestive of a pituitary macroadenoma with infracellular extension and bony destruction, invading the sphenoid sinus and clivus, with irregular edges and cavernous sinus invasion on the right side, suggesting an aggressive nature of the adenoma. This is the imaging CT and MRI and axial, sagittal, and coronal, which showing the destruction of the bony destruction. There is no invasion of the cellular floor, no widening like in the adenoma, and invasion of the clivus, and a paracellular extension and invasion of the cavernous sinus on the right side.
Nehal, your audio has gone again.
Yes?
Yes, okay. We can hear
Okay.
now. Yeah.
He suddenly complained of dropping of the right eyelid and diplopia. The examination was significant for right side ptosis and diplopia, complete ophthalmoplegia, visual acuity, where hand motion on the right eye and 6 on 36 on the left eye. The endoscope transcranial surgery was performed. The procedure revealed a highly vascular and invasive tumor eroding the cell and filled the sphenoid sinus, suggesting of an invasive macroadenoma. The headache and the blurring of vision and visual acuity were improved. Also, ptosis and ophthalmoplegia were improved partially. Histopathological evaluation of the specimen revealed multiple glandular and acinar structures formed of cells with abundant eosinophilic cytoplasm. Some of the acinar species showed brownish pigmentation suggestive of bile, a picture of metastatic cellular carcinoma versus atypical pituitary adenoma. Immunohistochemistry, 𝑬𝒑𝒑𝒓𝒄𝒄 in synaptophysin and 𝒔𝒑𝒂𝒂 were done for confirmation. 𝑬𝒑𝒑𝒓 showed strong positivity, while the other markers, including synaptophysin and 𝒔𝒑𝒂𝒂, were negative, confirming the hepatocellular origin of the tumor. This is the histopathology and immunohistochemistry. Figure A is the hematoxylin and eosine, and B is the positive 𝑬𝒑𝒓. C and D is synaptophysin and 𝒔𝒑𝒂𝒃, which were negative. Further diagnostic workup was done. Abdominal ultrasound revealing 5 by 4 centimeter mass in the right lobe of the liver. Triphasic CT revealed average sized liver with coarse parenchymal attenuation, fine irregular border showing right hepatic lobe segment 7, ill-defined focal lesion measured 5 by 4.84 by 4 in maximum dimension, which showed partial enhancement at arterial phase, which was with washout in portovenous and delayed phases of picture of hepatocellular carcinoma. Whole body PET scan showed other metastatic focus, right lower lung, lobe lateral segment, pleural based nodules. Bone scan showed multiple bone metastases with active osseous lesion involving multiple cervical, thoracic, lumbar vertebrae, left clavicle, pelvic bones, and proximal femur bone. The patient received radiofrequency ablation of the lesion, chemotherapy with no brain radiation. The patient became uncompensated and died 4 months after surgery. He published a study titled Pituitary Metastasis of Hepatocellular Carcinoma as the initial presentation, a case report and review of the literature in 2023. He found only 11 cases of hepatocellular carcinoma metastasizing to the pituitary gland have been reported. They were mostly elderly patients with a background of hepatitis, heavy alcohol consumption, and hepatitis B surface antigen positive. The mean survival was 4.9 months. The common site of metastasis for hepatocellular carcinoma are the lungs, lymph nodes, and less common bones. Pituitary metastasis of hepatocellular carcinoma is rare and can be misdiagnosed as pituitary adenoma. Although hepatocellular carcinoma is a frequently occurring malignancy, brain metastasis is infrequent, especially without the involvement of any other site. The reported, this is a summary of the 11 cases reported of the pituitary metastasis from the hepatocellular carcinoma origin. 𝑬𝒑𝒂𝒃 found 6 out of 11 cases representing themselves primary like pituitary adenoma with or without neurological deficit. In the other 5 cases, the symptoms of the hepatocellular carcinoma were the initial clinical presentation, like abdominal pain, ascites, and splenomegaly. The usual radiological imaging finding for pituitary metastasis of hepatocellular carcinoma with initial neurological symptoms is difficult to distinguish from pituitary adenoma. Arterial spin labeling in MRI may also be a useful tool to distinguish pituitary metastasis from the pituitary. The hyperperfusion nature of the tumor in metastasis is more common than in the pituitary adenoma. Some radiological differentiation between the pituitary tumor, pituitary adenoma, and the pituitary metastasis. Large mass typically involve both the supracellular or infracellular compartment. As they are usually rapidly growing, they were bony destruction rather than remodeling. Sclerotic changes around the cell lateral dural thickening, dumbbell-shaped mass with irregular edges, as the diaphragm cilia has not had time to be stretched, invasion of the cavernous sinus. Involvement of the infant typically appears as nodular or irregular thickening and enhancement with loss of a high-intensity signal from the pituitary. Although these findings may indicate the possibility of metastasis, they are in no way specific for pituitary metastasis. Management options: surgical resection, radiotherapy, chemotherapy, and immunotherapy or conservative approaches. Surgical resection provides symptomatic relief but is not associated with increased survival. Total resection via the transsphenoidal approach is technically challenging due to invasion of the densely packed adjacent structures, such as cavernous sinus, and due to high vascularity. Radiotherapy has a complete symptomatic relief and may be better tolerated than surgery due to fewer complications and can be the more easily delivered option in the patient in the palliative technique. The prognosis of the patient diagnosed with pituitary metastasis is poor, as they usually occur in the context of advanced disease. Estimated survival between 4 and 12 months. No treatment has been shown to have a significant survival advantage, but younger age, smaller volume lesions, and the time between the initial disease diagnosis and the pituitary metastasis presentation have been associated with longer survival. Take-home message: although extremely rare pituitary or skull-based metastasis can occur and may present itself as a pituitary macroadenoma, diagnosis becomes difficult if they are not accompanied by symptoms and signs of primary malignancy or other metastatic involvement. Although surgery not improve the prognosis, but it is indicated for better quality of life and to confirm the diagnosis. Thank you. And sorry again for this technical problem in my microphone, and sorry for your precious time.
No problem, Neha. At least we could hear you.
Thank you.
It was a very rare and interesting case of pituitary metastasis. And we don't see them that commonly. Professor Kato, would you like to say something?
I think it's very, very rare case.
Yes,
very,
yes.
It's
in the review, in the review literature, only 11 cases of epithelial carcinoma were published till 2023.
Okay, but Kozak Sensei is a very specialist of the pituitary surgery, so maybe Kozak Sensei, please make some comments.
Thank you very much. Can you hear? Can you hear
Yes.
me? The sound is so howling.
Yes.
Maybe at first I saw a small MRI, but the preoperative diagnosis is not typical macroadenoma because the tumor invaded to the 𝑘𝰵𝑵 sinuses. So at that time, you mentioned about the pituitary metastasis. Then you check the body PET or tumor marker or something. I think a little bit different to typical
think that is invasive pituitary adenoma. First, because pituitary metastasis is a very rare, and I did not get in my mind at all, if just after histopathology.
Okay.
Thank you.
Professor Kostadin, you have some comments?
Well, it is a very interesting case, certainly. What I would like just to say is that from a rarity, particularly like the hepatocellular case, in general, pituitary metastases are not going to be a rarity very soon, and little by little they're increasing in number. The matter is that I remember one study a long time ago, 20 to 25 years ago, when either in Sloan Kettering or in Anderson Cancer Center in the United States, on 500 consecutive fatalities of cancer, they found about 3 or 4% asymptomatic pituitary metastasis from those disease cases from cancer. So it is not rare. Now, with much better treatment of cancer in general and longevity of these people, we will be seeing them much, much more. So it is really an important thing. The other thing which I saw in the presentation which attracted my attention was that the incidence of breast cancer is dominating. I don't know the referral area in the population of the center, but most probably lung cancer is the dominating metastasizing disseminating lesion. So that is an interesting observation too. In general, the management is definitely surgery as much as possible, very often subtotal. Now, is considered some kind of stereotactic or other kind of radiotherapy that can be given additionally to such cases, because very often that can be an option.
Yes, Dr. Kostadin.
Yes, please. If there is any consideration for the stereotactic radiosurgery or anything like that, because that can be also helpful in such cases that actually will increase the survival span. The survival, yes.
Yeah, I'm not sure about it. If someone has some opinion on this, they can. Dr. Irfan? Dr. Irfan, you want to say something?
Dr. Kazaji?
Irfan, please.
Hi.
Irfan is my colleague, so please.
Oh, okay.
Okay. Thank you. So, thank you, Dr. Nihal, for nice presentations. So, it's very interesting presentation, and the case that present pituitary metastasis resembling pituitary macroadenoma. But as far as I know, the brain tumor metastasis is most likely the imaging presentation is resembling about brain abscess. Here, my question is that also possible for pituitary metastasis with imaging presentation also resembling a pituitary abscess? And that's my first question. My second question is that since the most common tumor in pituitary metastasis is breast cancer, how about in the female? Is there any explanation about that? Thank you.
Nehal, you'll have to unmute the other one. We cannot hear you. We cannot hear you. Unmute from your phone. Unmute your phone.
Okay.
Yes, go ahead.
The brain metastasis, many times we found it cystic degeneration and ring enhancement, and this is already like the brain abscess. But in the pituitary metastasis, it is a very rare, and I have no experience in this. This is the only case I found on my life, and I hear in my department from about 30 years old, I didn't found any case, so I have no experience in this matter particularly, but I wanted to present it to flashlight on this condition only. And I found the breast cancer HR2 positive. Some study found that the anti-treatment of the treatment of the breast cancer with HER positive can attract the pituitary, the metastatic cells to the pituitary gland. This is published in the one study I read. This is the answer of the two questions.
How about in female? Is the predilection since that female? How about in male patient? Is that also any information about the most common primary tumor for male patient? Your case presented about hepatocellular carcinoma, but is there any data regarding any primary tumor?
The breast cancer is the most common for the pituitary metastasis. Okay, but in males, the hepatocellular carcinoma is the first common type for pituitary metastasis. Usually, old age, alcohol, hepatitis positive.
Okay. Thank you very much for your answer and your presentation.
Azadi?
Okay. Thank you very much for presenting this very interesting case.
Thank you.
In my experience, I have experienced only one patient. On the clinical basis, it was a rapid onset of this vision going down, and particularly first the vision field, and then progressively also the vision itself, and pan-hypopituitarism. And it was a known patient who had actually cancer of the lung, and we opted not to operate on that patient, and actually he went to another country for further treatment, but he died very quickly within, I think, 2 or 3 months. Yeah. So the other thing I wanted to mention is that the hepatocellular carcinomas, in our experience, we get the metastasis first to the spine, and then eventually in other organs. It can be lung, and it can be elsewhere. Now, I have one question about the approach to this kind of tumor. Is the supraorbital approach more appropriate?
Sorry. The question again, please.
Is the supraorbital, yes, is the supraorbital approach more appropriate?
No, in this case, we go through the transconidal approach, endoscopic. And the lesion the lesion go to the sphenoid sinus and eroding the clivus. So the transaortal which may be away from this location.
I mean not transorbital, supraorbital.
Sorry?
Supraorbital.
Supraorbital approach?
The supraorbital approach. Yes, supraorbital.
Supraorbital?
Okay. Or Brown approach, supraorbital approach.
Yes. In this case, the lesion is intracellular mainly, filled the sphenoid. No supracellular extension. So it is easier to go through the endoscopic endonasal approach. With the mass lesion or the maximum lesion in the sphenoid sinus.